The American Cancer Society estimates that in 2018, there will be more than 97,000 new cases of colon cancer diagnosed in the United States.
The good news is that colon cancer screening is effective not only in detecting cancer in its earliest stages, but actually can prevent cancer from developing in the first place.
On this week's Health Talk, our guest, gastroenterologist Dr. Adam Gorelick, will discuss colorectal cancer screening, which could save your life.
So stay tuned for this important show. Health Talk is up next. Hello, I'm Dr. Eric Mazur.
And I'm Dr. Andrea Peterson. Today our topic is screening for colon cancer. Our guest is Dr. Adam Gorelick. He's a gastroenterologist with the Western Connecticut Medical Group.
Welcome to the show. Hi. It's good to have you. First time.
Thank you for having me.
Absolutely.
So colon cancer, very common cancer.
Very important topic.
Very important.
Second leading cause of cancer death in the United States.
And I guess one of the ironies is that colon cancer, we can screen for it, we can detect it in its earliest stages, we might even be able to prevent it. Why? Well, tell us a little bit about the biology of colon cancer.
So colon cancer starts, we believe, in a polyp. A polyp is a small growth or wart that grows inside the colon lining, and the colon's about 5 feet long. It comes up the left side of your abdomen, across the top and down the bottom, ends by your appendix on the lower right. And we believe that a small polyp, over about 10 years, will turn into cancer, going through different phases of what we call dysplasia, where the cells kind of become unorganized and then become a cancer.
And you can see these polyps when you look up into the colon.
That's right.
Using colonoscopy.
Yeah, when we do colonoscopy, which we feel as gastroenterologists is the gold standard for prevention of colon cancer, we see those growths, and we can remove them at the same time.
And that's the really important part, is not only can you see them, but you can do something about them.
That's right, at the same time without having to come back again for another procedure.
So you can remove those polyps at the time of colonoscopy, and that polyp is basically cured and will not go on to develop cancer in that location.
That's right, that polyp is gone. We send it off to the pathology lab, and we get a report back about what type of polyp it is. Different type of polyps have different risks for when you need to come back again for colon cancer screening. The two broad categories are adenomatous polyps and hyperplastic polyps, and it's important to know because if you are a maker of adenomatous polyps, you are at increased risk for colon cancer. So if we identify you as that type of individual, we'll bring you back sooner to have your next colonoscopy. And also important is we'll be able to identify you and your family at increased risk, and you could tell your first degree relatives and make sure they get screened at the appropriate time.
I think that's such an important point. So family history is definitely a risk factor for colorectal
Absolutely.
cancer.
It's one of the biggest. If you have a first degree relative, a parent, a sibling or a child that had colon polyps or colon cancer at a young age, under 60, you are at a large increased risk for having colon cancer yourself.
Which is really, so this is, not only are we detecting the precursors of colon cancer earlier, we're also helping to establish risk for that patient as well as their first degree relatives.
That's true, and even their second degree relatives to an extent, because if you have more than one second degree relative, they're also identified as at risk. So it's a very important step. The problem is not everybody that needs to get screened gets screened. In 2013, I think we were only screening about 60% of the population that's appropriate for screening was getting screened. So we were falling very short on getting the patients in.
So this is a preventable cancer that we're not fully utilizing the tools that we already have.
That's true, and what's really important is identifying the cancer early. Even if you have cancer, the earlier we identify it, the better the chance for cure. If we identify a small cancer in somebody that doesn't have any symptoms, their chance of survival from that cancer is very high, upwards of 80–90%, as opposed to waiting till you get symptoms, which is another important aspect.
Right. Once you have symptoms, that symptoms may be a lot of bleeding or even worse, obstruction of the bowel, and by then that cancer's got to be pretty big and far advanced. So.
That's exactly right. So we want to screen people before they have symptoms, because if they develop symptoms, again, it's too late. And the main symptoms you want to look for and ask about are rectal bleeding, as you identified, abdominal pain, or change in bowel habits. If somebody is regular every day going to the bathroom and all of a sudden there's a change, that's an important feature that they should mention to their physician. Yeah. Especially if they have not had a colonoscopy when they were supposed to.
And I think some people tend to assume that some blood that they may see on toilet tissue is benign or from hemorrhoids, but it's always worth going to see your physician and discussing that, isn't it?
That's true. There are different characteristics of those findings and those features of rectal bleeding. The color characteristics, frequency, whether it's associated with pain or not, that the physician can kind of get into further to see what's the appropriate way to investigate that.
So let's say standards for screening. What age does somebody start to think about a colonoscopy? And then we'll talk a little bit about some of the other screening methods.
So the standard is at age 50 is when you should start screening, unless you have one of the higher risk situations. So age 50, the typical recommendation is to have a colonoscopy, but there are other modalities as well that could be used.
If you have a first-degree relative who was diagnosed at an age earlier than 50 or had polyps at an age, does the screening recommendation change?
Yes, exactly right. So if you had a first-degree relative, you would start screening at age 40 or 10 years younger than the age the individual had the polyp or the cancer. And again, it's not just colon cancer, it's colon polyps. So if you had a brother that had an adenoma at 42, you're going to be screened yourself at age 32 or above, or any first-degree relative of that individual.
We do know that colon cancer is a disease of older people, but it can affect younger people.
Well, that's very true. Typically, more than 90% of the colon cancers occur in somebody over the age of 50. So it is the older population, but the biggest growing segment is the younger, the millennials. The 30, 40-year-olds are now getting colon cancer, and we don't really understand why, but we're seeing it more often, and we're taking those rectal bleeding symptoms more to heart, and we're investigating a little sooner these days.
And we certainly know with inflammatory bowel disease that those patients are at high risk.
That's exactly right. So inflammatory bowel disease is another situation where the patients that have that are at higher risk for colorectal cancer. So we will screen them earlier, and it's really based on the length of time they have their disease, whether it be ulcerative colitis or Crohn's disease, and the amount of bowel involved. The more diseased colon that they have, the earlier and the sooner we'll begin the screening for them.
And we also know that there are some families who have family syndromes that predispose them to colon
That's right.
cancer.
So two of the main ones that you hear about are FAP, or familial adenomatous polyposis, and the new one, HNPCC, well, not so new, but hereditary non-polyposis colorectal cancer. Those are two syndromes where people get colon polyps at an earlier age and they have a higher risk for colon cancer. People with FAP, they may get hundreds and thousands of polyps just after puberty, and they 100% universally get colon cancer, and they'll get their colon out when they're quite young. And HNPCC is important because it's also associated with some other cancers, such as ovarian, uterine cancer, and stomach cancer. So knowing your family history and some other high-risk situations is important.
A colonoscopy requires a clean out ahead of time, and I know a lot of patients hate the clean out.
It is the worst part.
So there are people that talk about the CAT scan type screening,
virtual colonoscopy,
which I think also requires a clean out, but you could correct me if I'm wrong.
So generally it does.
So yeah, tell us about some of the others, that and maybe the occult blood testing and the genetic testing.
So we'd like to think about the testing for the screening for colorectal cancer in a couple of different categories. There's the prevention tests, which when you go in there, you actually remove a polyp and do something that will prevent colon cancer. You'll find things earlier. That's colonoscopy, which we discussed. Flexible sigmoidoscopy is a shorter version of a colonoscopy. You're basically looking at the first or the lower third of, or one half of the colon, and if you find a polyp, then you would have that patient undergo a full colonoscopy. And the other is virtual colonoscopy. So that does require a clean out as well. Generally speaking, there are some newer studies where they're being able to radio label stool, and when you have the scan, they can kind of subtract it off their images. What a virtual colonoscopy does is it's a fancy CAT scan. It takes multiple slices through the abdomen, and then a computer generates a three-dimensional image of the colon, and the radiologist can actually do a fly-through as if they're going through a tunnel of the colon and see the growths on the wall. It's a virtual trip through the colon, and they can see the growths on the wall. Again, though, if you do have that and they find something, you're going to need a colonoscopy. So you'll go through the preparation and the procedure, and it has some risks associated with it. Number one is the radiation exposure. But it does miss the flat polyps, which are one of the more one of the hot topics you hear about now, these flat polyps, which are we think the deadly ones because they're easily missed, and the endoscopy
kind of flat against the wall.
Yeah, they
of
grow
the
very flat, and they have a different sort of lining. And the newer scopes today, with these high definitions, and we have different light available to us, we can really enhance and see those polyps a lot more clearly as we're going through. And the radiologist doesn't have the same opportunities to do that.
And how about some of the non-invasive tests?
So the others are the...
I think Cologuard is advertising very heavily on TV. What is that? So
Cologuard is one of the detection tests, and that's the next category besides prevention, or detection. The typical ones you may have heard about or experienced in the past are the detection tests for blood. The stool hemoccult test that your doctor used to send you home with a strip of cards to put some stool on there for 3 stools in a row and send it back. That detects microscopic amounts of blood from colon cancer or a very large polyp as the stool is going past the polyp or cancer. The Cologuard actually detects some of those cells that the colon cancer or large polyp are sloughing off from day-to-day activities in the stool going past, and it actually detects the DNA in the stool from the large cancer. And it's a great test if you have cancer. So it can detect cancer greater than 90%. The problem with the test is it misses, it only detects about 40% of the large, more aggressive polyps, and it doesn't do anything for the smaller polyps as far as finding those that colonoscopy would remove. So there's a bit of a gap there. So if you do the Cologuard test, if you have a positive test, you'll need to have a colonoscopy to find out what's going on inside, what shed the DNA that was detected. And the problem is, in one of the studies, the false positive for that test is about 10 to 15%. So we may have a false positive test, go in there and find nothing, and then you're not sure what to do. So the jury's still out on that. But if you do a Cologuard test, you'll be repeating it every 3 years if it's negative, moving forward from that. And the colonoscopy would be every 10. If you have no polyps on your colonoscopy, you're good for 10 years. If you're at average risk, flexible sigmoidoscopy would be 5.
We have about half a minute left. Any last words for our viewers maybe about colonoscopy? You know, it's hard to consider sometimes.
I think the most important thing for patients is to make sure you get screened. And the screening test doesn't really matter. The more important thing is just getting screened. And have that discussion with your physician. What's the right test for you? And that's the more important thing. What values, what issues does that individual patient have? Bring it to the table so they can make the decision that's right for them. But just getting screened is the most important thing.
This is such an important piece of information.
Absolutely.
Thank you very, very much. Really
joining
appreciate
us.
it. Fortunately, we have run out of time. We want to thank our guest, Dr. Adam Gorelick, for joining us on Health Talk today.
If you have questions or concerns or comments for us, please do email them to us at healthtalk@wchn.org.
Thanks for watching.
Stay well.